Hello, everyone. I'm Shellys Cyr and a proud member of the class of 76 and a current Bowdoin trustee. Today's program is entitled COVID-19 Presents Opportunity and Challenges for Medical and Life Sciences Experts. And I am absolutely delighted to be able to welcome alums, students, faculty, staff, and community members with, of course, a special shout out to the class of 76 as we celebrate our 45th reunion. Woohoo! Of course, we'd all rather be at Bowdoin in person and once again have a chance to see J. Taylor Crandall in his Madras sports jacket. I promise that will be my last Insider 76 joke, but I am grateful that we can come together virtually. I especially want to thank Lindsay Lassard and Casey Hintz from Alumni Relations for their incredible support in putting all of this together. So before we dive into the substance of today's program, let me cover a couple of webinar details. Closed captioning will be available throughout the program for anyone who would like to use it. After the presentations from our panelists, there will be time for them to answer audience questions. So I invite you to use the Q&A function at the bottom of your screen to post your questions at any time during the session. So with that, I think we're good to get on with the show. So I am so happy to be joined by my three amazingly accomplished classmates. They are Alison Brent, who is Medical Director for the Network of Care and Physician Relations at Children's Hospital Colorado and University of Colorado School of Medicine. Hi, Alison. Next is Michael Fiore, University of Wisconsin Hilldale Professor of Medicine and Director of the University of Wisconsin Center for Tobacco Research and Intervention. Hi there, Mike. And then finally, Shaun Gilmore, who's the Chief Transformation Officer at the American Red Cross. And sorry, Alison and Mike, but he has the coolest title. So rather than doing individual introductions, which I quickly realized could eat a considerable chunk out of our program today, I've asked each of the panelists to introduce themselves by describing some of the highlights of their journeys from Bowdoin to where they are now. So Alison, can you get us started?
Thanks, Shelley. I'd love to do that. And thank you to Bowdoin for inviting us to have this amazing little mini reunion with all of you and share a little bit about ourselves and our experience in COVID. So it's always easy for me to chat about Bowdoin. It's one of my very favorite topics, and especially how I got from Bowdoin to where I am today. Bowdoin really is a common thread in my life in general, I think, as well as my career. And I think Shelley will acknowledge that being among the first class of women was initially probably equal parts terror and excitement, having no idea what to expect. But it turned out to be one of those amazing once in a lifetime experiences and made friends that have lasted a lifetime. So it was undoubtedly one of the highlights to start my life, and a huge shout out to all my 76 classmates, and so wish we could all be together doing this. But as you see how my career progressed, you'll see the common threads and how it all actually relates back to Bowdoin. I like being the first to do something. I like doing something new, taking a chance. And I do like living on the edge with terror and excitement. So there you go. After Bowdoin, I graduated from medical school at Brown. And from there, I decided to go into pediatrics, trained at Children's Hospital in Boston. And for some reason was really attracted to sick kids, which probably doesn't sound very good, but they're great protoplasm. They get better quickly. And I just love the environment. I also really like critical care and knew I wanted to do something in that field and was really drawn to the ER. I love making organization out of the chaos down there. It was really fascinating. But at that time, there was no pediatric emergency medicine. For all of you young people out there, you probably can't imagine that there was a time that wasn't a specialty, but there wasn't one. And in my third year of training, Children's Hospital Boston said, we're going to create a brand new specialty training program in pediatric emergency medicine. And of course, I applied. I thought this is absolutely great. And after I got accepted, I got called into the chief of pediatrics office at Boston Children's, who said, you silly girl, you are wasting your career on this flash in the pan specialty. You probably should do something else. So just like Bowdoin, I said, oh no, I'm sticking with it. This is going to be really exciting. So, of course, I jumped on board for that, had a great fellowship training. And then after fellowship, I really got my start in new program creation, which was really kind of fun. I got a call and recruited by UMass Medical Center, who wanted to create a pediatric ER for the first time. And I said, sure. I was just too young and naive to know what that undertaking was all about. And so started on that pathway and really just loved it. Started doing clinical research, which I loved, focused on sedation and analgesia in kids, making sure that every kid would have a pain-free ER experience, and just loved pediatric emergency medicine in general. And then I got a call from All Children's Hospital in St. Petersburg, Florida, who said, hey, we are building a brand new pediatric ER down here from the ground up. Would you like to be involved? And I said, well, of course, I love doing first things where there's no background whatsoever. So I jumped right in there. And when I got there, it was like going into the Freddie Flintstone pit, because there really was a big hole in the ground. And that's what it was. So I got to work with the architects and the engineers, actually built the ER up, able to hire all the people, get the equipment from all over the world, whatever I wanted. It was kind of like winning the lottery of pediatric emergency medicine. So that was a really exciting experience. Started a fellowship training program there. And just when I kind of thought I might retire with my office overlooking the bay and seeing sailboats go by, I got a call from Colorado. And I was like, wow, where is Colorado on the map? And they said, hey, we want to build a brand new system of care in Colorado, and we hear you do this kind of work. Would you be interested? So what did I say? Of course, you get the thread now. I said, yeah, that sounds like a great idea. I'd love to come to Colorado and do that. So I did end up coming to Colorado, and over the past 16 years have been on just an amazing journey. We have built 5 hospitals. 2 of them are freestanding children's hospitals in the Denver Metroplex area. And we've done a lot of cool new things, which I'll talk about later. But then COVID hit. So Shelley, that's how I got from Bowdoin to here.
That is amazing. I've never thought of our time at Bowdoin as terror and excitement, but I will never forget it now. So thank you for that, for sure. So Shaun, can I turn it over to you and have you tell us about your path to from Bowdoin to where you are now?
Yes, thank you, Shelley. And you're probably wondering how this guy got on the panel, right? Because you're talking about healthcare and life sciences, and probably wondering how someone from the Red Cross fits in there. So I'll talk about that in a second. But as I look back, my whole career definitely came out of Bowdoin. I first went to Bowdoin. I really wasn't sure what I was going to do. Wasn't sure what I was going to major in. So I took a lot of courses in different topics. And based on that, I found sociology, which I really loved. But I was thinking, I'm not sure what I'm going to do with sociology from a career standpoint. So I said, I better major in something that can, get me into the business world if I need to. And somehow I determined that was economics. I'm not sure, I was smart enough to figure out economics isn't business, but so I majored in economics and business. And while in sociology and economics, but while at Bowdoin, in the sociology department, Matilda White Riley, who was a renowned sociologist, came to Bowdoin as the head of the sociology department, and she just inspired me. And she was just a great professor, a great head of the department. She gave me an opportunity to do research in sociology, and really inspired me to think about what I could do, coming out of Bowdoin. In addition, while I was in sociology, shortly, maybe the year after Professor Riley came, another gentleman came who both had a sociology advanced degree and an MBA from Harvard. And so I was thinking, well, maybe I could do sociology and get an MBA from Harvard. But anyway, as I was continuing through my course of, I think it was my junior year at Bowdoin, I was, someone from the financial aid office called and said, you're being considered for your scholarship from the George F. Baker Foundation. And I said, well, does it change how much, financial aid I get or not? And they said, no, it comes from the George F. Baker Foundation. So I said, well, that's great. Thank you. I appreciate that. I later found out that the George F. Baker Foundation was a major contributor to the establishment of Harvard Business School. And actually, it's the Harvard Business School is the George F. Baker Foundation is attached to that. And I also found out that they would pay to send me to any business school that they approved of. And I didn't have to pay for it, so they would cover my tuition and books, etc. So not surprising, I ended up applying to a number of business schools. Was fortunate to get into Harvard Business School, probably because Professor Riley, wrote one of my recommendations. I'm sure that carried some weight as well. And at Harvard, and coming out of Harvard, I took a position in a management leadership development program at AT&T. At the time, this was 1980, AT&T was the largest company in the world. But I took a position in their leadership development program, which moved me around to different departments every 18 months and progressing through the organization. And at the end of, X number of years, you have made your way through virtually every department, functional department in the business. So at the time that I was, at AT&T, before I left, I was president of the Northeast Division of AT&T, which was principally the communications piece. It's not the AT&T today. It's the old long distance and local operation. And that time it was the long distance operation. So like Alison, I got a call from a gentleman who wanted to. I asked me if I wanted to come and be president of a small operation, small business. I think at AT&T, some of the businesses I had were in the multi-billion-dollar range. This company had a revenue of 80 million, and most of it was in a division that he wanted me to be president of. At that time, the company was private and about to go public, and so I joined just prior to that. Went on a roadshow, did the whole IPO thing, which was a great experience. But then I had to come back and actually run that company. And the company wasn't quite the same as was represented on our roadshow or on the slides. So anyway, I spent a year and a half at this company as president of this small division. It was the worst experience I ever had. It was financially worked out great, but I went through 4 root canals in the period of 18 months because I was gnawing my teeth away at night because I just hated that environment. And what I learned from that is I never wanted to work in an environment where I didn't respect the people or I didn't have fun with the people I was working with. So anyway, I left there, ended up joining a small startup in Denver, based in Denver, called Quest Communications. Eventually bought one of the old baby bells and grew into a larger company. I spent 4 years at Quest Communications, running some of their large operations, their internet business, their Fortune 500 business, government business, etc. And then there was a change in leadership, and I was tied to the old leader, and so I made the decision to leave there. And coming out of there, I was recruited by a venture firm to be a president of a small company, again a private company. Which I did. And then this was in 2002. In 2002, I retired. And my daughter was just going into high school. And I figured, wow, what a great opportunity to go through and help her through high school. She didn't think it was much help, by the way, but I thought it was very magnanimous of me to do that. But I got to enjoy her, her 4 years of high school. And then one day, a friend of mine, a colleague, and a really good friend and a colleague of mine from AT&T, became president and CEO of the American Red Cross. And she reached out to me, another call, like Alison, got a call, and she said, would you like to, join the American Red Cross? And I said, well, I'm retired in Denver. It kind of feels pretty good. And she basically said, don't you think you should be doing more with your life than sitting on your butt in Denver, Colorado? And of course, I said, no, I'm fine sitting on my butt in Denver, Colorado. But anyway, I joined the American Red Cross, long story short. I've been there 13 years. I joined as president of their biomedical business. This is what connects us into the healthcare industry, which really oversees all their blood operations. When I joined, it was a 22,000 person organization. represented about 2/3 of $2 billion plus revenue, or cost reimbursement really, for the American Red Cross. I did that for 9 years and oversaw all their blood operations. And for the last 3 years, I've been doing transformation work. And I do have a cool title as the Chief Transformation Officer. I sit around all day transforming stuff. It's really cool. Yeah, no question about it. But anyway, that's what I've been doing for the last 3 years, and was involved in a number of initiatives, including what I'll talk about a little bit later. So that's my experience.
It's a great story, Shaun. And is your daughter happy that you're?
Well, yeah, I think she is now. I think she, in retrospect, appreciated it more than when she was going through it.
Sure. And of course, today everybody's at home with their kids who has kids of a certain age. So there you go.
Yeah.
Excellent. So Mike, you're up next. How did you end up in your current position from Bowdoin?
Thanks, Shelley. As you mentioned, I'm a physician and professor of medicine at the University of Wisconsin School of Medicine and Public Health. I've not gotten a lot of calls. I have actually been on the faculty here for 33 years. My passion has always been preventing disease, with a particular focus on seizing the healthcare visit as a moment to help individuals who smoke to quit. Most smokers want to quit. About 80% of them visit a healthcare setting each year. And my work is focused around how to ensure that every time a patient who smokes presents to a healthcare setting, he or she is urged to quit and provided with treatment. This sounds simple, but unfortunately, it still only happens with a minority of patients who smoke. And I've done this work in two ways. First, I've led a center at the University of Wisconsin that I founded in 1992. It's made up of 50 clinicians, scientists, and staff, all devoted to helping people to quit. And secondly, for the last 30 years or so, in a variety of capacities, I've assisted the United States Department of Health and Human Services, including the National Institutes of Health, on tobacco cessation policy issues. In essence, how can we create policies that make it easier for individuals addicted to tobacco use to quit? Bowdoin provided a foundation for everything I've done since I graduated. In the fall of 1972, I left my Italian-American home in Boston, the proud son of Rebello and Giovanna Fiore, neither of whom had graduated from high school, but both of whom passionately wanted me to go to college and beyond, including possibly medical school. I was clueless how to do this, and Bowdoin took me in, teach me about the world and how it operates. And it gave me friends who I care about deeply to this day. And I just want to end with one last point. I was able to attend Bowdoin only because they provided me with scholarships and loans. And for that in particular, I am so grateful.
That was great, Mike. And yes, me too. I was so grateful for Bowdoin and this financial aid. And I'm grateful to you because every time I see a patient now, which is not that frequently currently, but when I do see patients, I have to ask them about their smoking. And that was your contribution, which is just enormous, that physicians have to ask about smoking at every visit, and it makes such a difference. So thanks for what you've done. So there was a question that I think probably warrants my making an announcement that I probably should have said at the beginning, that this is a webinar. It's not the usual Zoom format. So participants don't need to be on their best behavior. The panelists do. So don't relax. But you can imagine it was someone from the class of 76 who asked if they needed to be on their best behavior. So there you go. But no, this is a webinar. We cannot see you. We cannot hear you.
Well, that's concerning.
Yes. So, oops. I just lost my Zoom here. There we go. So I don't know why it took me so long to realize this, but it was only recently that I learned that it was Longfellow Bowdoin class of 1825, who will not be at the reunion this year, who wrote the often quoted line, "Into each life some rain must fall." Did you guys know that? That he wrote that? Yeah, I don't know. Somehow it evaded me. But this was from his poem, The Rainy Day. So I've got to say that these past 420 or so days have felt more like an unrelenting hailstorm than a passing shower, as we've all experienced various forms of disruption and challenges and loss. So at the start of the pandemic, healthcare leaders and practitioners were asked to hit the ground running and to react to what was happening in real time. This resulted in some transformative change, as you can imagine, both some good and maybe some not so good. What I'd like to do now is to ask each of our panelists to speak about their work and as they experienced it in the early pandemic, maybe share a story about some progress that they made or maybe something that didn't go as well as they had hoped. And for this, I'm going to turn it over to Shaun.
Okay, great. Thanks, Shelley. So my experience through the pandemic, obviously there was a big impact on the American Red Cross in terms of blood donations and responding to disasters and sheltering people and all those kinds of things. But I was asked to stand up a process for the collection of COVID convalescent plasma. And I've kind of thought about this, and the way I was describing this to my fellow panel mates here was like the rise and fall of COVID convalescent plasma, or CCP. And it was just an incredible experience to go through that. And I want to share with you two aspects of that I thought were noteworthy, and talked about in connection to Shelley's question about hit the ground running and the expectations that were around that. But I also want to talk about science, and science is a very topical issue these days, and interpretation of scientific fact and evidence, etc. A lot of division around that, I know. But I'll share with you what my experience was with science as we went through this whole process. So let me start out by talking what is COVID convalescent? What is convalescent plasma? Convalescent plasma is really about collecting a unit of plasma from someone who has recovered from a disease. And the science behind the efficacy of convalescent plasma actually goes back over 100 years. And it was used successfully to treat people during the Spanish influenza outbreak, measles outbreaks, diphtheria, as well as many other diseases. And so as we were entering the first phases of the infections with COVID-19, and people were looking for solutions. What do we do? There was a groundswell of thought around, well, why don't we collect convalescent plasma from people who have had the disease and recovered and use that to treat patients. Now, there was really little to no talking about the scientific evidence around the efficacy of COVID convalescent plasma versus the treatment for other diseases. In fact, there was I think there was one study that was based in China where it appears the virus started. And I think it was 7 patients, only 7 patients, and there was no control patient. All 7 of them got the convalescent plasma. And from that study, it suggested that it made a difference. No one died from those 7 people, and people actually progressed and got better in a reasonable period of time. But that was the only scientific data that we had. We didn't have more than that. And so what was happening is, in the absence of any other therapeutic, if you will, that could treat COVID patients, besides ventilation and, et cetera, COVID convalescent plasma really started to gain a foothold. And the early process, because it wasn't tested, it wasn't approved by the FDA for regular use, but it was approved by the FDA under what they call an emergency use authorization, where they said under certain guidelines that they established, we will allow people to transfuse COVID convalescent plasma into people who are suffering from that disease. But they had a set of requirements. First of all, the person had to have a prescription from a doctor. So it had to be prescribed as a treatment. And it was, transfused into the patient, and there was other requirements, in terms of, general health and things of that nature. But since it was still starting out, there wasn't, it was a very manual process at the Red Cross. At the time, we were doing maybe 5, procedures a week, maybe 10, after a couple of weeks. And it was all manual, very labor intensive. And what was happening is they were only directed donations. So this was someone who says, my father has COVID and I want to donate, I've had it and I want to donate plasma to help him, or someone else, or someone that says, one of my friends has COVID, I've recovered from it, so I want to donate. So there were only what was called directed donations, and the plasma only went to that person. What happened in March of I guess late March into early April, this was late March, the FDA came to the Red Cross and said that they would like us to set up a nationwide process for the collection, testing, distribution, etc., of convalescent plasma. And the American Red Cross covers about, we supply about 40% of the nation's blood supply. But under this, they asked us if we would do this for the whole industry. And so I was asked if I would stand up this operation, and from March until mid-July, end of July, this is what I did: 7 days a week, probably 16 to 20 hours a day. And it was just an intense process. So when we were looking at setting that up, once again, at that time, there was still no efficacy data that suggested that convalescent plasma was a valid treatment. There was, stories of, people who had recovered from or gotten better from the disease having received convalescent plasma. There was newspaper articles about people, who recovered from it. And again, in the absence of any other, key therapeutic that could be used for treatment, people were this was the thing they focused on. We were getting calls from people that, were demanding that we give them a dose of convalescent plasma. I mean, the stories would break your heart, and we had very limited convalescent plasma, did most people. So the FDA asked us to start this up. They asked us to do it across the industry. We assembled a group of the industry players. There's 35, I think at the time there was probably like 55 or so other blood banks throughout the country. We were the largest, as I mentioned, to the Red Cross. So we assembled them and tried to work with them in terms of setting up this process. Surprisingly, the blood business is highly competitive, and not a lot of those other blood banks want to work with the Red Cross because they want the Red Cross to get the credit for the work that they were doing to support this. So we ultimately ended up just separating into American Red Cross and non-Red Cross, and we focused on the Red Cross in terms of our process and procedure. So in order to do that, we did set up, though, a national website for people who had COVID-19 and wanted to volunteer as a donor to register. And then we would run them through the process of eligibility. They had to have a confirmed COVID test, for instance, to say they truly had it before they could donate. They had to meet other requirements in terms of 29 days after the last infection, or 14 days. Those changed a little bit during that period, et cetera. But as we were trying to set that up through that whole period, I was constantly getting calls from FDA and others, saying, you're not going fast enough. You're not going fast enough. You got to get this up. And suggesting if we didn't, then, I was going to get a call from some general who I don't even know, and that this was really a big deal. And I understand that it was a big deal. But with that pressure, to get this up and running, we launched the website. And we figured, let's just get the website out there. We'll collect, applicants, etc., and then we'll work it through the process, and the process will still work. The process was still going on. That was a big mistake. What happened, and it's actually a great thing, but we just got overwhelmed with applications. I think in the first 2 weeks, we had over 30,000 people volunteer to donate convalescent plasma to help someone. And these aren't directed donations. These were, I'll donate it for anyone. So we moved from the directed donations, where we stopped doing those because of the labor intensity of those, and moved to, we're just taking donors, and then we're going to send those to our hospitals who have a demand for that convalescent plasma. So 30,000, that was just phenomenal. The humanity of people is just incredibly was incredibly evident during the pandemic. And as always, my 13 years of the Red Cross still amazes me how generous people are. The problem is we didn't have the systems behind it and the processes in line. So it just kind of crashed. So we had all these people calling us and saying, hey, I want to donate, I'm taking my donation. They were going to the press, saying the Red Cross isn't taking my donation, et cetera, et cetera. So, in essence, we just were able to, in, the period of a couple of weeks, put in place the number of people. We just threw people at it. We changed processes. We did more technology, et cetera. And we got that process to where it was really humming along fairly well. Through this whole period, however, there was still no data in terms of, is convalescent plasma, COVID convalescent plasma, effective in terms of treating COVID patients? What the FDA did in May is it was actually Health and Human Services asked the Mayo Clinic to expand its utilization, this emergency use authorization, and do a study of the effectiveness of convalescent plasma in the treatment of COVID. And so Mayo was collecting information from the people who were using the emergency authorization by the FDA in order to distribute the convalescent plasma. And they were looking to collect about 20,000 different records. But, as they were going through that process, we still didn't have any data that says this is really, effective. What also happened in May is the White House launched Operation Warp Speed, and to develop vaccines and other treatment options faster. And what they've done on vaccines is just nothing short of incredible. However, on convalescent plasma, their decision was, they wanted to really speed up that process. So when we first set up this process with FDA, I asked them what's your forecast in terms of demand? And at the time, the gentleman I was working with at FDA said probably 5,000 to 10,000 doses. When Warp Speed came along, they decided that at that time, they wanted to put this into Warp Speed. And they asked actually the Red Cross and the rest of the industry to collect 500,000 doses as quickly as possible. Now, as you may know, convalescent plasma is not a manufactured product. It's a biologic, right? You need plasma from people who have been infected, with the disease and have this, the adequate number of antibodies in their plasma to be able to be used as a treatment. So, but anyway, and talk about, expectations of hit the ground running. They said, we want 500,000 as soon as possible. I reminded them that there weren't enough donors in the U.S. that have recovered from COVID, from COVID-19 to be able to even come close to that volume. In fact, if we could get 100,000 doses out of the people who had recovered from it, then we would be in good shape. Because just because you had COVID doesn't mean you could donate because you're not eligible. Some, younger people, older people, underlying health conditions, whatever. So, but anyway, so we worked our way through those expectations, and we were waiting for the Mayo Clinic data to come out. A couple of months went by, so we knew there was some issue that with the data that the Mayo Clinic had collected. And in essence, what it came down to is they were looking at everyone who had been transfused with convalescent plasma. So there wasn't a control group to look at there. So people were skeptical about the results. and basically saying, but you're only looking at people who got the vaccine, not people that got the placebos. And therefore, there was there was some general suspectness within the scientific and health communities around, will the data really be proved that it is effective? What by the end of 2020 and into early 2021, actually back up in late August, actually the published data from the Mayo Clinic came out, and it did indicate that convalescent plasma was safe, which we knew at that time because we had done studies on that, the industry had. But they said it's really only effective when it's used to treat infections early on in the process, and as long as it has a sufficient concentration of antibodies, enough that it will make a difference. So the evidence that we were waiting for, the scientific evidence to support this massive collections of convalescent plasma, really just didn't come to pass. By the end of 2020 into early this year, all sorts of other therapeutics started to emerge. As you know about antibody cocktails, different types of obviously vaccines as well, but other therapeutics, that have come on, remdesivir and Regeneron, et cetera. So the demand for convalescent plasma just started to, since there was no scientific evidence other than in certain instances, the demand for it really kind of abated and really leveled off. At the time, the blood industry has collected over 700,000 doses and distributed 700,000 doses of convalescent plasma. And it is still used as one of several treatment options today. But the two things I want to share with you that came over that is, the whole expectations about hitting the ground running and the whole science. And so the whole frenzy over the availability of convalescent plasma in the early days of the pandemic really resulted in unrealistic expectations around how many potential doses could be made available and how quickly they could be made available. So it was to see the rise of that and the pressure. We need more and more. We're waiting for the scientific evidence. We're investing money to collect these units of blood. The government was, by the way, reimbursing us for the cost of that. But we're collecting. We ramped up. We stopped collecting other products to do this, and then lo and behold, once the scientific data came out, it just kind of dropped by the wayside. So the lesson I learned beyond, in this kind of frenzied environment, not to try to cut corners or to go too soon before you have complete alignment of all your processes, not just the marketing piece of it. But I also learned that there's really no substitution for data-driven decisions. Obviously, we took a leap of faith, and sometimes you have to do that and make a judgment based on what data is available to you at the time. But there really is no substitute for data-driven decisions, especially when it comes to science. So that was my experience with convalescent plasma.
Thanks, Shaun. What a ride. I mean, really,
Yeah.
It was incredible. So Alison, can you share what this has all been like for you through a pediatric lens?
Absolutely, Shelley. And I have to say, Shaun, I would think you're a physician the way you talk. You've got the speak down and right on, my friend. You would have fit in well with the other side of us. And I'll tell you what, in my early days in the COVID-19 pandemic, I would have taken convalescent plasma before every shift in the ER. Because I can tell you from the clinical side, every shift was just pure terror. You're dressed in this huge raincoat thing that doesn't breathe. You've got a face mask on, you've got goggles, you've got headgear. Sometimes you have a big beekeeper hood on, and then you realize you can't see. So anyway, I would have gladly taken that and the pre-vaccine stopped my worry load. But kids were a little bit different in the beginning. They weren't quite as sick as adults. That's changing a little bit now, but we did see some interesting things. One of them is that MIS-C, or the inflammatory syndrome that you may have heard about on the news. And some of those kids are the sickest kids that I've seen in my entire career. So COVID really walloped kids from, newborn babies, 3-day-old babies, to kids in college. So it was everyone. But one of the things that I found from the administrative side of my life is the tremendous need to share information from experts throughout the community and even the world. So I am going to do a little shameless plug for a podcast that we started, and then tell you how we were able to pivot that during the pandemic into something that could help out with COVID. So let me see if I can share my screen here. Can you see that, or did that not come up?
We can see it. Oh, it just
Okay.
went away. It just went
All
away.
right. All right, let me try it again. All right, well, I might try that again later. It worked in the trial, but it didn't work now. But maybe somebody on the Bowdoin side can help me put that, or try putting that slide up for me. But I'm going to do a little shameless plug for a podcast called Charting Pediatrics, which is a weekly pediatric healthcare podcast that we started 4 years ago, where we drop a new podcast every week that talks about the latest treatments, innovations, delivery of care for pediatricians worldwide. And I can tell you, if you're interested in learning more about that podcast, you can find it on Spotify, iTunes, Google Podcasts, Google Play, or wherever you do download your podcasts from. So what's interesting and ties back to my Bowdoin career is that in starting this podcast, I am honored to be one of the 3 co-hosts for this. 3 of us are physicians. We have no media background, communication skills, nothing. We just decided, hey, let's start this podcast. And we had great support from our hospital. And we started out obviously with 0 podcasts downloaded a month. And now we're up to like 55,000 podcasts a month that are downloaded worldwide. And we can get my slide up, you can see we are now in 173 countries, and I couldn't even name 173 countries. Obviously didn't take too many geography classes either, but couldn't tell you that. And our listener population is very loyal, and we get great feedback from them. And we thought, there it is. We thought, wouldn't it be interesting if during the pandemic, we can pivot this podcast to focus on COVID-19. Might talk about things from, what Mike's doing, what Shaun's doing with plasma. We had our pediatric ID experts. We all took turns interviewing them. We interviewed people from all over the country. And during the pandemic, we were able to do 36 COVID-related podcasts that had 173,000 unique downloads just for the COVID piece of the puzzle, which we thought was great. So anyway, thank you for putting that slide up, and you could take that away now. But we just thought that was an amazing way to harness technology and really get the word for COVID out there. We were kind of playing the Tony Fauci of the West and seeing how much we could share information. On the other information sharing front, rather than just the podcast, we felt the need to get it out in our region. So we started a town hall weekly where we focused on some experts in the fields of infectious disease, epidemiology, school, government, telemedicine. And we were able to reach over 500 practices in the sort of 7-state region throughout Colorado. And then as the months went on, we were hoping that maybe the demand would go down. The demand persisted for this information. And we actually had people phoning in from all over the US, which was really very exciting. So we would start our town hall, much like we do this. We had a little initial presentation, didactic, followed by a Q&A session. And we're really able to answer the questions that so many people have, both in big areas of cities in Colorado, but out west, it's a lot of big square states. It's not like New England where everything's close together. So we were able to reach all kinds of practices, both in the city and rural. And Shelley, that's my experience of some impacts during COVID.
Love it. So are you going to continue these things, Alison, the podcast and the town hall?
Well, the podcast, definitely. I think we're going to pivot away to new hot topics. Very sadly to say, we had to intersperse a gun control one in Colorado when we had another fatal shooting out there. And we'll continue with the town halls as they're indicated, but we'll probably pivot that. They'll never go away, might be focused on different things in the future. Hopefully someday we are going to get away from COVID.
That would be great. We are all looking forward to that, are we not? Yeah,
Absolutely.
definitely. So Mike, you certainly have a unique perspective, focusing on sort of analysis of COVID outcomes and especially around addictions. So could you tell us what this experience has been like for you? Mike, you're on mute. I love saying that. I was actually on a Zoom call where somebody had it on their t-shirt. But I'm getting really good at reading lips. Can you unmute yourself, Mike?
Will
There.
do. Sorry about that. And you're able to hear me okay now?
Yep.
Excellent. So the links between smoking and COVID, clinical settings have evolved dramatically over my time as a physician. And one big part of that has been the evolution of the use of electronic health records, or EHRs, to document clinical care. And I spent a lot of my time working with the EHR, investigating ways that this technology might help more individuals quit smoking. One of our goals has been to literally bake in to healthcare visits, tobacco cessation treatments, and doing that as seamlessly as possible, integrating questions, prompts, reminders, evidence-based guides, so that busy clinicians can address tobacco use. And that brings me to COVID. COVID has upended medical care in so many ways. And we've heard quite a bit about that already. Healthcare was overwhelmed with acutely ill patients, treating a new disease, and not having many of the typical tools physicians lean on to treat, including, as was mentioned, a solid science basis of best practices. In particular, clinicians lacked one of the fundamental rules of the road, and that is information on the progression of a disease like COVID that will allow them to triage patients based upon their characteristics and history. And lacking this information, physicians could not then develop targeted treatments. So to help meet this need, and based on my prior work with technology, the National Institutes of Health in April 2020 reached out. Specifically, they asked us to use this EHR technology experience to rapidly collect EHR data on as many COVID patients as possible, with the goal being to identify what characteristics and historical factors of the patient were associated with them either surviving or succumbing to COVID. So over the next few weeks, we started this work in April of 2020. We partnered with 21 healthcare systems across the country. They agreed to share their EHR data on every one of their COVID patients and promised to update that data drop every month. It was an incredible and an uncommon degree of collaboration, all in the interests of advancing the common good and our understanding of the disease. By the end of 2020, our sample included health information on over 600,000 COVID patients, about 2% of all COVID patients in the United States at the time. And I thought I'd share with you some of the observations from those data. Some of these are ones we already knew, and some were contributions of new knowledge. The first, overall, women were more likely to get COVID, but men were more likely to be sicker with COVID, to be hospitalized, and to die if they got the disease. Second, being a racial or ethnic minority was a giant risk factor for severe COVID disease. Blacks were about 50% more likely than whites to be hospitalized with COVID, and Hispanics were about twice as likely as whites to be hospitalized. One variable all of us have already heard about, age, was without a question the most powerful predictor of severe disease. In general, hospitalizations for children, adolescents, and young adults were relatively uncommon. Among those aged 70 and older, more than 20% who got COVID were hospitalized, and these individuals died at a very high rate. Obesity was a powerful risk factor, both for hospitalizations and death. When we looked at past medical conditions, renal failure, particularly individuals on dialysis, those were those who were most likely to get COVID, to be hospitalized and die from it. The link between COVID and smoking, what we initially were asked to look at, was another particularly harmful one. Individuals who are current smokers are much more likely to be hospitalized. And finally, among these 600,000 patients diagnosed with COVID, about 2% of them died. And when we zeroed in on the approximately 80% of patients who were hospitalized, about 10% of them died. You asked Shelley what surprised us about our experiences. One is the incredible interest in being part of an initiative like this one. The NIH asked us to try to get data on about 10,000 patients. We ultimately got data on more than 600,000 in 2020, and they've asked us to do it for another year, and we believe we'll be over 1 million COVID patients by the end of the current year. And it's all individuals who are wanting to do anything to help in overcoming this disease.
Yeah, that certainly seems to be a theme in terms of the humanity of people and the collaboration that you might not have seen otherwise. To have that many health systems actually contribute data is truly remarkable. So really, really impressive. I just have to ask you this, Mike, do you have any hypothesis as to why obesity is such a powerful risk factor for bad outcomes?
It's a great question. You know, obese people in general are at risk for virtually everything.
Right.
So they have a lot of other comorbid disease. But one of the observations we had in treating really sick COVID patients were how to position them to get the most air into their lungs. And we know that any really obese patient, we have a harder time ventilating them if they ultimately have to go on a ventilator. And it's probably just a simple mechanical issue, although I would say that's just a hypothesis.
It's a good one though, definitely. So as you all look into your crystal balls, because I know you have them, right? Your class of 76, you must. So what things do you think are here to stay once we hopefully get back into a pre-pandemic mode? Maybe something that might be a silver lining to all of this, something good that comes out of it that stays. Alison, do you want to take that?
Yeah, I can start with that. I think, Shelley, I hate to tell you, I think one thing that's sticking around is Zoom meetings. So, you know, I'm not sure we're ever going to get back to the old days on that one. But for me, I think that the silver lining for COVID has been telemedicine. I have long been a proponent of telemedicine, believe that it's really the future for best delivery of care. And pre-COVID, there were so many government regulations on doing telemedicine. There wasn't equity in payments. There were just a lot of governmental hard stops on doing this. Once COVID hit, the government relinquished all of those holds. Telemedicine could be done however you wanted it to be done. And I know in an academic setting, we saw in one day, we turned all of our ambulatory visits from in-person to telemedicine. So all the people who said they couldn't possibly do telemedicine, probably including us, were able to do it. They figured out it was just a very easy thing to do. So I think that has really been great. It's been good for kids in getting them back into the office. For us at an academic center, we were also able to put telemedicine devices in every inpatient bed and every ED bed throughout an entire hospital system to decrease PPE use and increase connectivity of specialists with patients. So I'm really excited for the future. I have the privilege of working with the AAP on telemedicine, and making some of these government changes permanent for the future will really be the ultimate silver lining to COVID.
Oh, good for you. And I'm totally with you on this. I mean, what we're seeing is that people who may not be able to access care easily are able to do it more easily through telemedicine. So maybe they don't have transportation, or particularly for mental health services. And of course, there's so much of a greater need during the pandemic for those. I think that's another place where we can make a big difference. I guess the dermatologists are, they're thrilled, right?
Yeah, they're loving it. And one of the things that Mike touched on was the some of the inequities that we see across the country in terms of access to care. One of the things that the American Academy of Pediatrics is really focusing on, and hope will become something that we can do, is, much like in a lot of cities, you can, rent a scooter for a little while, or a bicycle or something else. But we're talking about kids being able to rent iPads or watches or something else, really improve the broadband, really get that equity out there among the population to access medical care.
So maybe I could just jump in one other thing. I definitely agree that telemedicine, and I mean, it's a non-health issue, but telebusiness, by the way, is something that I'm sure is not going away either. I live in California, although my office is in Washington, and I moved out here a couple of years ago because my daughter moved out here, is a common theme. And once she moved out here, after a year or so, we had asked her, are you ever coming back? Because she was in DC where we were. And she said no. So we decided that we would move to California. And the trips from California, Southern California to Washington are just an all-day affair. So I'm looking forward to that. But on the medicine side, I think the other thing is the speed to market. If you look at how quickly products are coming to market, how quickly the vaccines have come to market, I think you're also seeing the emergence and acceptance of biotechnology. I mean, again, look at the mRNA virus vaccines, the monoclonal antibodies, and the effectiveness of those technologies in helping us work our way through this pandemic. I'm not sure that we'll ever be willing to accept anything less than we need a vaccine, next month, or in 6 months or 9 months, or we need better solutions here. It's just been phenomenal. And I was ragging a little bit on Operation Warp Speed, but that pressure to get stuff done and taking the funding issue off the table in terms of people or companies having to commit capital resources to be able to invest in technologies that may not come to pass or may not come to be effective, it was a big part of that. So I'm not sure we'll ever go back on those fronts either.
That's a really, really good point. So Mike, how about you? What do you think's here to stay?
Well, I just want to echo the transformation to delivering care through a Zoom meeting or the equivalent of that. And Alison said it, but I just want to highlight it. It is helping to be more of an equalizer. If you have even a smartphone device, you can take advantage of this. And there's just been such fear around COVID, and different people have manifested that fear differently. But to be able to tell a patient that I'm going to be there with you, I'm going to talk with you, I'm going to hear you, and you don't have to run the risk of coming into a healthcare facility where you think it is full of individuals with the virus, has been really powerful.
Indeed. Indeed. So we have had the opportunity, unfortunately, to witness how fast misinformation can spread, right? I mean, I think it's been spreading almost as fast as the virus. How have you all handled the misinformation, either with your patients or families, colleagues, or the public? Want to try that one, Alison?
Boy, that's a tough one. You know, I think the biggest thing that we get in my world has really been vaccine hesitancy. And overcoming that. I mean, the anti-vaxxers are a huge problem for us in pediatrics. I completely believe in vaccines, and I wish more people would come out and say that so firmly. So we just really, you know, I think we've learned that the best way to do that is to listen to them, to see what their fears are, and then hopefully, you know, share some data on a go forward basis from that point.
That's great. Other thoughts? Shaun?
Well, for us, it was, you know, there was a lot of misinformation out there about, you know, all sorts of things, and whether it's vaccines or you know, treatments for COVID. And I mean, we can all remember how, you know, some of the treatments were hard to believe people were suggesting. And at least from my perspective, it was, you know, finding, and I know this isn't going to come across well, but someone that we thought was kind of a true north, you know, in terms of, you know, one person that, or a group of people that, you know, we could always point to. And, you know, we could point to the CDC, and you can point to NIH, and you know, can point to some others. But, you know, for us, it was Dr. Fauci. And I know he's coming up on a webinar. I think he's going to be getting an honorary degree too. But I mean, and I know people have different opinions about him. I love him. I love him. And I think the way he carries himself, the way he delivers the message, the way he doesn't get you know, flustered, you know, when attacked. And you know, this is the, you know, this when I see, you know, how he is treated in some, you know, forums, I think it's terrible. You know, I think back to the Kipling poem that says, if you can keep your head when all about you are losing theirs and blaming it on you, that's Fauci, right? You know, people are saying, you know, you can't do this or this, and, you know, and didn't you say this early on? And yeah, early on, a lot of us didn't know what was happening here. So for us, it was, you know, keep to the science, and we would follow CDC guidelines, whether it's on, you know, protection of our employees who are collecting blood or plasma, or keep going into our shelters in the case of natural disasters and things of that nature. You know, we followed the science. But, you know, and from my perspective, it was also having a little bit of a North Star that we could, you know, focus on, say, you know, this person really speaks. When he speaks, you know, we listen to him.
Yeah.
I think that's great.
Yeah.
Yeah, and he's going to be part of Polar Bear Nation, as you said, and he's
Yeah. Cool.
doing a talk on May 19th. So I'm considering this sort of the warm-up act for Tony Fauci.
He's much better than me.
Yeah, I agree. I've got a Tony Fauci T-shirt that I love to wear. I just want to add one more thing, that it's not necessarily misinformation, but I think it's something that in medicine we always have a hard time conveying, and that is that all risks are not equal. And that's been such an issue with COVID. You know, you know, what are the most important things people can do to protect themselves? This is a respiratory virus, so obviously addressing that. And I know I had to deal with quite a bit in terms of my own patients and others who became very concerned about some aspects that might not make as much sense, like washing everything they purchased at a supermarket. I really liked, Shaun, what you said about True North and the power of Dr. Fauci to help us with that. And I think we're finally down to some really simple messages. You know, wear a mask, keep your distance, of course, get vaccinated. But we've taken a long time to get here. And part of it is just the challenge of all of these decisions had to be made in real time. And boy, was that challenging.
Yeah.
In many cases, in the absence of data to support them, right?
Right. And that's another theme clearly that's come through is, you know, sometimes you have to do that in a crisis, but, you know, ideally you would wait for the data. Absolutely. So I am looking at some questions that are coming through the Q&A. And so one is for you, Shaun, if you're willing to take it. It's blood donations for $100. You don't have to answer in the form of a question. But the question is, overall, how's the amount of blood donation going during this, during the COVID, in the mid-COVID world?
Yeah, it's been up and down, to be perfectly truthful. When the pandemic first hit in the March, April timeframe, I mean, all of our blood from the Red Cross, in fact, all whole blood donations are through nonprofit blood establishments like the Red Cross. So, we depend upon volunteers. We don't pay for anyone to come in and donate blood. There are paid for plasma centers out there, but most of the whole blood collectors are nonprofits, do-gooders, like I say, like the Red Cross is. But our supply comes from people. And, we work with sponsors of blood drives, and 80% of our blood comes from sponsored drives versus Red Cross facilities that recruit and collect donors into our facilities. And when corporations were shutting down, we run drives on corporation campuses. We run drives on schools. In fact, colleges and schools and universities, the education segment is our largest blood donor segment, accounting for over 21% of our blood. And schools shut down. Then you had community groups and faith-based groups that weren't meeting anymore. So it was a big hit, in the March, April timeframe. And what we were able to do to recover from that, a couple of things helped. One is the demand for blood went down as well, because people were postponing elective surgeries. They weren't out driving on the road, so you didn't have as much trauma, need for blood, et cetera. Unfortunately, some people were postponing treatments for cancer and other things that rely on plasma, platelets, whatever the case may be, or whole blood. So those things were happening, and that drove the demand down a little bit. But for a while there, we just weren't sure how we were going to reach donors who came to us through their churches or through their work or through their schools. And what we were able to do, which I think two things really helped. One is we started to ask those same sponsors and some of our other partners, like for disaster services, for a disaster response, where a company may give us a facility, or a school may give us their gym and to set up a shelter, or a faith-based organization may allow us to use their building, et cetera. And so we went out and we asked all our partners on our disaster side if they could make the space available for what is now could be a natural disaster, a blood disaster. And many of them did. So they opened up, they weren't necessarily in session, but they opened up their facilities and allowed us to come and set up a remote operation as a Red Cross fixed site, is what we call it. And then we were recruiting donors to come in and donate there as well. The second thing that really helped us, to be perfectly truthful, is we started offering antibody testing as part of a donation. So when people are coming in, we say, we'll test your blood, because we're doing tests for all sorts of other things. We'll test it for antibodies, and we'll tell you if it's a positive test. And that actually brought a lot of people in, and who could not only donate blood, but could get their blood tested to see if they did have antibodies from COVID-19. So those two things definitely helped. But it was a real tough time there in the beginning when our whole source of blood donors just kind of disappeared overnight.
Yeah.
Now, the blood demand just at the current time is starting to pick up a little bit. Mm-hmm. And there's really a severe shortage right now. And in fact, we're in what we call emergent.
Whoops, Shaun, I think you may have frozen. Am I right about that? Okay. We will get back to that. Hold that thought, Shaun. So I'll move on to another question and see how we do here. We'll get Shaun back, I'm sure. So question is, I'm curious to know what you think about the announcement of potential intellectual property waiver on vaccines. Too little, too late if you live in the parts of the world that have no production facilities, question mark.
Well, that would probably be a great one for Shaun, but I'll weigh in for whatever it's worth. We're just seeing what's happening in India, for example, right now, the tragedy of that country, and the potential to have more vaccine available to more people. I think the public health world recognizes that's what is needed to be on the other side. Of course, releasing intellectual property guidelines does not necessarily mean that the quality assurance needed to do and produce a safe and effective product is necessarily there. But assuming that that were to be the case, this is such a remarkable moment in our history that if we in fact can get more vaccine to more people, it would, I think, be very reasonable.
Definitely. You're back, Shaun. I'm sorry. We lost you there for a little bit.
Yeah, I was assuming the answer wasn't any good, so you just cut me off.
I do not have that power. No, I would never do that.
I think some of it is related to the difficulty in the manufacture and the storage of the vaccines. If you think of how delicate the mRNA vaccine is, and people probably don't realize how delicate that is and how easily it can be destroyed. So you really need, the reliable Volkswagen version that can be mass produced and easily stored and transported and given in roving ways as well as just in stationary.
Yep, absolutely. I mean, that's what's so appealing is the one and done vaccines, right?
Yeah, exactly.
Right. So here's a question from a rising fourth-year medical student.
Ooh, we like this.
I know. We're so sorry about the disruption of your medical education, I'm sure. So rising fourth-year medical student, and they met several patients in the hospital and in the clinic who are reporting post-COVID symptoms and long-haul COVID. I'm curious to know, is this a topic something that any of your institutions, organizations are now pivoting to help understand and treat? Let's see. Is it something that you've considered, and the pandemic course started to shift within the US? Thanks again. So how about long haul COVID? We're learning a lot about it, I know. What's happening?
That's one of the unique things about COVID is that we learn something new every day. And that's one of the things that I like about medicine in general is every shift I work in the ED, I see something I haven't seen before, but COVID is a whole new animal. And I think the problem is that no one really knows right now why we get COVID or why we get the long haul syndrome, but in the end that this answer will come out. So that fourth year medical student can be part of unraveling the mystery. I'll be interested to see what my colleagues think, but there are a couple of ideas out there from the ID community. One is that we tend to see it more in people who didn't have as severe an infection initially. So there's some thought that you didn't have a robust enough immune response that allows for some long-term low-level disease to go on. Question we get a lot is how long is it going to last? I'm like, we don't know yet. We're just following the data right now, and we love to follow the evidence. So someday we'll have the answer to that question. And then another school of thought is there may have been some damage done initially by the virus that allows certain systems in the body to continue to manifest symptoms, but we don't know. And Shaun and Mike, I'd love to know what your thoughts are, or what new things you may have heard in the adult world from what I hear in pediatrics.
Well, this is less so patient specific and more from a public health perspective. There are two giant cohorts in the United States now that are collecting longitudinal data. So we've got patients who got COVID and we're following them over time. One is both of them are sponsored by the National Cancer Institute, and one of them is ours. So we're not just collecting data at the time you get COVID, but every time you return to the healthcare setting. So we'll be able to really, because the numbers are so large, really dig deep into say, what are the characteristics of me who gets it versus you, Alison, who doesn't? And what is the nature of the presentation over time, including how long it lasts? So I sure don't have a sense of the etiology of it, but I think we'll get a better sense of who's at risk and if there's anything that mitigates it in terms of interventions that are done, because these very large cohorts also cover the medications that are given to patients over time.
So one cool thing that I can tell you about that we're doing in the pediatric world is we have a lot of kids with a long-term loss of taste and smell, which is driving everybody crazy. So one of our ENT doctors has actually started a clinic that's at 3 of our freestanding hospitals where they do olfactory retraining. And there's some old literature on actually how to do this, because there's different ways that you can lose your smell. And then there are 4 different scents that you have to smell so many times a day. And they're doing a longitudinal study on these kids who they've enrolled. I think they get the scents free from whoever distributes them, because they all have the same package of stuff. So it's kind of interesting. You know, one of the other benefits of COVID is the incredible ingenuity that we've seen and creativeness that people are thinking of. Like, who would think of an olfactory retraining clinic? But I'll tell you what, that is one of our busiest outpatient clinics. And we'll see, it may turn out to be like there's no evidence behind it. But kind of like Shaun said, you know, we try everything and see, because people are looking for hope out there.
That's very cool. Very cool indeed. So another question is, will the FDA continue to fast track with other diseases like ALS perhaps? What do you think?
Well, I don't know if any of us have any inside information on the FDA, but as Shaun,
Yeah.
as Shaun mentioned, you know, the whole warp speed activity was just remarkable in so many ways, but it was remarkable also because they took out the financial risk to the companies, and for uncommon diseases like Lou Gehrig's disease and others that we would love to get answers to. It's so uncommon that no matter how much one would charge for the medication downstream, it's hard to have an economic argument to do it. And it's a real tragedy for families who are suffering from these diseases. So it's not only allowing them to fast track it, but it's also the economic wall that has to get over to show that a drug in the United States is safe and effective.
Yeah, I think that's the real issue, more so than the fast tracking by FDA.
Yeah, definitely. So Shaun, stay unmuted there, because there's a question here for you. Even though convalescent plasma did not live up to the early promise for COVID relief, did the experience lead to other areas of potential that might prove positive?
Well, not specifically for COVID convalescent plasma. I mean, it's still being used as a treatment, and it does have some efficacy for certain for certain people early on in the infection curve, if you will. But beyond that, where the good news is it's plasma, so we can freeze it, and we can freeze it for up to a year, and it will still be good. So we are keeping the plasma. We're not throwing it away. We're keeping that plasma, and it may find a need, or it may be some other study will show it's effective in some other way that we haven't noticed yet. But again, with the new emergence of other therapeutics, just showing such good results, and especially apparently when they're put together in a cocktail form, and then the vaccines being so effective, et cetera. I'm not sure if the questions is specific to convalescent, to CCP, COVID convalescent plasma. I see any other use for that at this stage, at least. I don't know if my fellow panel mates have any thoughts about that. That's way outside my lane in terms of additional uses.
So we are getting toward the end of our time together. So I'd like to go back to your Bowdoin experience. We'd all like to go back to our Bowdoin experience, right? So do you have words of wisdom and maybe optimism for Bowdoin students who have had their education disrupted in such a profound way during the pandemic? Maybe some lessons that you've learned along the way in your career paths that you could give them optimism.
Well, just a couple of thoughts. One is, and I know this isn't going to make people feel better whose career college years have been impacted by COVID, but just going to Bowdoin, I mean, and participating in the classroom discussions, with the professors and others, they're just top notch, and being inspired by professors as I was, and that doesn't have to be face to face. It's a little bit easier building relationships face to face if you're a freshman, for instance, or this has impacted you for your freshman and sophomore year. But just going there just made a big difference for me. It opened up a whole new world to me. Like I said, I didn't know what I wanted to do before I went there, and I found what I love to do, and ultimately was able to to kind of still have that focus around people and be in the environment I want to be at. As a second career. I mean, again, I was retired. I wasn't planning to go back to work before I went to the Red Cross. And one of the things that attracted me there, as I mentioned, is, there's a group of people where we all work together. And we grew up at AT&T. And the president, CEO went there as, an AT&T alumni, one of my friends. The chief operating officer is one of my good friends. The president of our training services is one of my good friends from AT&T. And back to you can build a cohort of relationships and network, and Bowdoin is a great opportunity to do that. I was able to do that, but also in a corporate setting and leverage that. I think the only advice I have, because I think it's really hard, and I couldn't imagine going through, especially as a freshman coming in, perhaps, getting indoctrinated into the school. And I know how much of the learning process takes place outside the classroom. So I would encourage you to take advantage of what is available. And I just saw an email come today about Beyond the Gates or Through the Gates or whatever. We have a series of different programs, as well as this program, where you can continue to get experience from, in learning from people outside of the school, or where there are events where you can get together as a Bowdoin event and see your classmates and interact with the classmates and participate in those kinds of activities, as this pandemic works its way through.
It's great. Yes, I've got to say the Bowdoin network is very powerful. So I totally agree. Anybody else with any words of wisdom or pearls for students?
Well, one thing I'll say is I hope that someday Shaun will hire Mike and me into his company and we don't have a job somewhere else anymore. And Shelley too. Wouldn't that be fun to all work together? I would absolutely love that. I think a couple words of wisdom I would say is, I think we've all heard the adage, what doesn't kill you makes you stronger, or maybe a little touch of adversity. So I think I found throughout my career path, when there's a little adversity there, it just makes you stronger. So just really, rather than bucket, embrace it and figure out how you are going to be the next level coming through. You'll be so much better than all of us at, virtual meetings, telemedicine, telecommunication, telebusiness, whatever. So harness that. And then for you guys who are still at Bowdoin, and if you might be pre-med, I made a huge error in that I really focused on science courses because I thought that was the only way I could get into medicine. And once I got into medical school, I started taking like art history and just loved it. And I never took an economics class, so all I can do is balance my checkbook. So I really didn't get a full and balanced Bowdoin education. So I would say take all those fun courses you want, and you'll probably be more attractive to getting into any grad school that you'd like to in the future.
How about you, Mike?
Well, I think the wisdom is substantial. It's been shared. I'll just say two things. One is I imagine a lot of people feel as though, boy, this really sucks that I lost this year, and there's no taking that away. It does. The one thing that, and this has been mentioned particularly by Shaun, but the network of relationships that most people develop at Bowdoin that continue for a lifetime is part of the experience that cannot be taken away from you. And you know, to the degree that those can be nurtured during these particular times, what a maybe an opportunity there. But the people you're with in your class, in other classes, nobody can take those relationships away.
Yeah, absolutely. Those are great words of wisdom. And I totally agree. The other thing I would add is Bowdoin alums love connecting with Bowdoin students and other Bowdoin alums. So even if you haven't established a network, you can get one after you graduate. I mean, I've just had such fun meeting with Bowdoin students, hearing from them. So, and I'm sure all of you have had as well. But I think that's just, it seems to be universal among Bowdoin alums that they're very, very willing to give up their time, as you have been today. And I really appreciate it. So this has been a fabulous session. I have so enjoyed hearing your stories. I loved the themes that have emerged around, you know, we need the evidence, you know, we need to be able to pivot and to hit the ground running, but always with an eye to, you know, again, having the data when we can and collecting it going forward and learning more. So those were just terrific. And then, of course, the humanity that has emerged among people in this whole experience, and the creativity. And you have all been such great examples of the creativity that has happened around the pandemic with the fabulous things that you're doing to help us all weather this storm. So thank you so much for participating. And I want to thank all of the attendees for attending, for their questions. We weren't able to get to all of them, but I think we're able to capture them, and maybe we can get them to the panelists and have them answered at another time. So with that, I will just have one announcement, and that is the class of 76 does have a reunion event coming up on June 3rd, and more information will be available on that. And as you know, Tony Fauci will be speaking on, I think it's May 19th, I believe, and this is the warm-up act. So there you go. So thank you all so much. And for everybody who's attended, I say, be well. And if you haven't done so already, get vaccinated.
Amen.
Okay.
Thanks everyone. Bye-bye.
Thank you. Bye-bye.